Welcome, everyone, for another episode. We have an awesome guest today, Dr. Tad DeWalt. Thank you again for taking time out of your day to join us. This will hopefully be part one of a part two series that we're going into regen medicine and stuff like that. So Dr. Tad DeWalt is one of the, I would say, probably one of the leading experts in the nation on sports medicine, regen medicine, orthobiologics, and it's a blessing to have him on the podcast today, so we can talk all things PRP today, and maybe next time we'll talk more about stem cells and stuff like that. So, thanks, Tad, for taking time out of your day for joining us.
Well,
And
thank you for having me. This is an honor. So it's great talking to you, Ron. So yeah, I'm excited. I'm excited for this conversation.
yeah, and we'll have a link below for everyone that you could visit his website to find more information about that, what he does, and like what he specializes in and stuff like that. So today we're going to talk all things about PRP. So, Ted, if you can, what is a PRP injection?
All right. So the basic definition of PRP or platelet-rich plasma is concentration of platelets. So if you're starting with some amount of blood, your final volume will have a higher concentration of platelets. So you could cheat, you could take out 2 red blood cells and say, oh, that's PRP, but most of the orthobiologic or the regenerative medicine physicians will at least say it's at least 2 times the concentration of the platelets is considered a PRP. But you'll also see throughout this episode that we want a certain number of platelets to get a certain response. So in some conditions, that could be 10 billion platelets or 5 billion platelets or 1 billion platelets. But the true definition of a PRP injection is taking autologous blood, meaning your own blood, putting it in a centrifuge, either spinning it once or spinning it twice. We like to spin it twice, and concentrating those platelets to get a higher number of them to get a response from the tissue, whether it's tendon, ligament, muscle, or joint. But really, it's concentrating that to get the outcomes that we want. So a higher concentration of platelets in the product is the true definition of PRP.
Many patients ask this question, and you and I know the difference, but is a PRP injection a blood stem cell injection, or is it different compared to like bone marrow stem cell injection?
Okay, so it definitely is different. I mean, it's just using blood, and to be honest, if you take enough blood, there are circulating stem cells in the blood, but we are not doing that. That would be more like a dialysis procedure where all your blood's going in, we filter it out and come out. So no, this is not a stem cell injection, though it does stimulate more stem cells to go to the area of damage. So you can think of the platelets with the growth factors that are associated with them as chemotactic agents or stimulus for more stem cells to come to the area, but we are not truly injecting any stem cells in the injection. We're trying to get more stem cells to come to the area. So completely different than just a stem cell injection. And like you said, excuse me, that would be bone marrow or adipose tissue are the 2 areas that we get that. And this is a little off topic, but maybe for our next one, there is a technique where we can get what they call them mu cells, or very small embryonic-like stem cells that we can get from blood, but that is a whole different concept than the PRP.
Okay. So how does a PRP work? Say you do the procedure and you inject the PRP injection. Say it's a tendon or an injured tissue. How does the PRP injection work, and how does it help heal the tissue?
All right. And that is important. So we want to identify the area of damage first, see it with an MRI, with an ultrasound, with potentially just with an x-ray if we're dealing with arthritis. But we want to get to that specific location where, let's say it is a tendon, where there's bad parts of the tendon. So we're literally going right to the bad part where it's tendinosis. Most of these are chronic. Most of these are over over 6 weeks. So we're usually dealing with tendinosis more so than tendinitis, which is the acute inflammation of the tendon. But we inject it right into the bad part of the tendon, though the platelets are going to cause a reaction, all the growth factors associated with it. We have different degrees of leukocytes, which are the white blood cells. Sometimes we want more leukocytes, sometimes we want less. But all of it is doing is signaling the body that there is damage here. So more chemicals and more cells come to the area to heal it. And that's really what we want from the tissue healing, is that stimulus, like it's a brand new injury. So the body said, okay, that's new. Let's go and give it everything it needs to put down new collagen, new tendon, new muscle, whatever it is. So really it's that stimulus basically telling the body, all right, there's damaged tissue here. You haven't done a good job of healing it on your own. So this is the stimulus, so we can finally, truly, really heal this.
You did say something really interesting with acute versus chronic. Now, do you use PRP for more chronic, and then like a platelets poor injection or a PPP one? Do you use that for more acute?
And it matters what tissue it is. So if it's an acute hamstring tear in the muscle or a calf tear in the muscle, not the Achilles tendon or the hamstring tendon, then my go-to, and a lot of the other docs around the country or around the world, is PPP for muscles. So it's we're not trying to build up the collagen there. We're trying to heal it even quicker than what would be normal in the body. But we do use PRP for some acute stuff, but I would say the vast majority is, all right, you've got an injury, you're trying to heal it, it's 4 weeks out, it's 6 weeks out, it's 8 weeks out, it's not coming around. That's when we're going after it with the PRP. But there are some instances with broken bones or, fractured bones, or if there's a nerve that is really inflamed, where we're doing it more acutely, but the vast majority are for more chronic conditions. And like we just said, over 6 weeks from the time of injury.
Okay. You've already mentioned this with tendons, but what type of tissue works best or responds best to a PRP injection? Is it more tendons, ligaments, fascia, or like you mentioned, the PPP injection is best for muscle, possibly, but what are your thoughts on what tissue is best for the PRP injections?
So I would say probably the three that stand out the most are the tendons, so tendinosis. Then we have wear and tear or partial tears of ligaments. So that would be the second one. And then the third one are joints. So, whether it's the knee joint, finger joint, whatever joint it is, that would be the third. And I would say the most research has been done on joints, particularly knee arthritis, because that has the most pathology, in America and the world. Knees are what get arthritis the most in our society. So that probably has the most research. And then the second most research is tendinosis, partial tendon tears, those scenarios.
That's just interesting because you pretty much listed tissues that don't have great blood supply versus tissue like muscle and bone that have great blood supply, or more on the other one. So that's good. So what is, like, I've read some literature on the benefits of PRP injections on having 5 billion versus 10 billion. What is best practice when it comes to PRP injections? Does it vary per body part, per the tissue, or is there a best practice where you and other physicians are trying to get to that 10 billion platelet mark because the research shows that's best practice? What is best practice regarding PRP injections?
Yeah, and that matters if it is arthritis, the degree of the arthritis versus the tendons or the ligaments. So that 10 billion platelets is what we're aiming for any kind of arthritis condition. But let's say you have a moderate arthritis in a 25-year-old versus moderate arthritis in a 70-year-old. you're gonna want a little bit more platelets in the older individual than the younger individual. And same thing, if there's a 70-year-old with grade 1 arthritis, mild arthritis, versus a severe arthritis, a bone on bone, same thing. It's a dose response. So there's more we have to overcome. We need a higher dose if the arthritis is more severe. So it's variable, but 10 billion platelets is the cutoff, at least, that we want to get above, for sure. And to get that, you need a good PRP system, but you also need enough blood. So no matter what system you use, you'd probably need anywhere from 60 to 200 milliliters of blood to get that desired platelet count. And so we always test the platelets before, we do the blood draw, test the platelets before. That's an average between 150 and 450 as far as the starting dose, and that's times 1,000. But that's just a variable that people have. Some people are low on their platelets, some people are high. So if we're high on the platelets to start with, we need less total blood to get to that 10 billion platelets, where if somebody is low, then we're going to need more blood. And that can correlate with age and different health factors. But that's what we are looking for arthritis, is that 10 billion cutoff. If we're dealing with a tendon or a ligament, right now the current consensus is 5 billion platelets. And we can break down all the studies that are out there, where if we look at all the studies for knee arthritis, we look at the ones that are above 10 billion and the ones that are below, and we just throw out all the ones below, we're getting very high. We're getting over 90% success rate. That's what we want. But same thing, I explain this to patients all the time. You have high blood pressure. You need 40 milligrams of lisinopril to get better, to lower your blood pressure. If I give you 5 or 10 or 20, it's a good drug. It's supposed to do its job, but if we're not getting to that threshold, it's not going to lower your blood pressure. So same thing with the platelets. If we get above that 10 billion, we know from all the studies that you're going to have less pain, better function down the road for 2-3 years with arthritis if we get over that. So that's what we want for our patients, is not just to do a PRP, but a PRP we know is going to affect their function, better function, and decrease their pain. So that's what we're aiming for.
That's great. So what I hear you say is, too, there is a way to measure to get to that threshold, depending whether you want 5 billion or 10 billion. There's a way to measure it, and there's systems in place that you can get to that point to make sure that this is the best PRP injection for that patient given the actual injury. So that's good. Next question. You and I know the literature on this, but PRP injections versus corticosteroids. So we see patients all the time just getting corticosteroid injections when I'm like, man, I wish they would have had a PRP injection. But what are your thoughts on the outcomes and the research on PRP injections versus corticosteroids?
And as of now, there have been enough. There used to be way more studies on cortisone than PRP or stem cells and all that. And just this year, the PRP data actually surpassed the cortisone data. So we've done more studies on PRP for knee arthritis, for tendon issues, than we have on actual cortisone. So at least we have that data set now. And, everyone asks, oh, is this not covered by insurance because there's not enough studies? No, there are more studies now than what is covered by insurance, which is cortisone. So that is refreshing that we finally kind of caught up to that. But let me just tell you, so from the studies that look at it, you say we go a year. For 3 months, you're probably going to do better with a cortisone, or at least the first week or month. So basically, if this is time 0, the cortisone does really well for about 3 months and then kind of fades away. Some people might get 4 months, some people might get 2 months, but on average, about 3 months. The other one we haven't mentioned that is covered by insurance sometime is the hyaluronic acid or the gel injection. So that's a little bigger curve. So we start here, starts a little slower than the cortisone, and then about 6 months that's fading away. Where if we look at all the PRP data for the over 10 billion platelets, we're starting slower, but by 4 to 6 weeks, you're gonna notice it, gonna keep building at 6 months, kind of stabilize, and at 1 year, you're still doing well, could still be improving, or you're already at that good level and it's just kind of leveling off. So that's what we see for 1 year. For 2 years, obviously the cortisone's already done its job and it's out of the system. Same thing with the hyaluronic acid. But around 1 year to 2 years, that's where PRP is still doing good. Some people, if the arthritis is severe, you can start to have that fading away. So usually tell patients, you're at least good for a year. Some people go 2, 3 years, some up to 5 years, but on average, 2 to 3 years after, of good relief from a PRP for arthritis. Now so that's just for the joints. For the tendons, I hope nobody is injecting tendons with cortisone anymore, but I know that is not the case because so many of them come to me, oh yeah, I just got one. Or even if someone says for their shoulder, they got a bursa injection. If it's guided, if it's not guided, they're usually still going through the supraspinatus, infraspinatus in the back of the shoulder or on the side of the shoulder. So a lot of these people are getting the cortisone into a tendon when the goal of a cortisone is to calm stuff down, break stuff down. There's two types of cortisone, or not really cortisone, two types of steroids, the anabolic steroids and the catabolic. Anabolic, big bodybuilder. I mean, it's like the stereotypical thing that's building muscle, where the other steroids are trying to break down muscle. Or break down whatever they come into counter with. So anytime a patient has had a steroid, that's breaking down the material. Yes, it can help temporarily with the pain, with the inflammation, but whether it's in the joint with the cartilage, it's toxic to the cartilage, or into a tendon, it's toxic to the tendon. That is having the opposite effect that someone like you or myself want in our patients, where we want to build up the tendon, make them stronger, progressively load it so it gets better. That is not what's happening with the cortisone, unfortunately.
Correct.
So, but the good thing with the PRP for the tendon is, like I said, for the arthritis, eventually it fades away. You might need another one, or you might need to talk about stem cell. Where with the tendon, it is truly putting down more collagen, fixing those little gaps, those little tears, or the tendinosis. So that is a long term. Obviously, you can injure it again in the future, but that initial injury, that initial wear and tear of the tendon, majority of the time is getting healed, which is the exciting part. Instead of just modulating the pain and the function, we're truly healing the physical defects in the tendon.
Yeah, great stuff. So this is a question directly from a patient. How is PRP injections different from prolotherapy? So I guess first, for people who don't know what prolotherapy is, can you define what prolotherapy is? And then, what is your clinical expertise on PRP versus prolotherapy, and what does the research say?
All right. So I would say prolotherapy is a stimulus for healing. What they've been used historically has been dextrose, which is just a sugar. So basically, you're diluting it to whatever concentration, whether it's D50 or D12.5 or D7.5 or D5. It's that sugar water injected into a tendon or a joint that's trying to get a stimulus, just like PRP is trying to get a stimulus, trying to have more cells come to the area. Prolotherapy is doing the same thing, just on a much lower scale. So traditionally, a prolotherapy wouldn't just be one injection. It would be a series of minimum 5, sometimes up to 10 or 15. So it's doing that same stimulus that a PRP does, just in lower concentration or a lower stimulus level. And that's why you need multiple of those to kind of get the same response as a PRP.
What I hear you say is they're using dextrose in a diluted solution to inject it to induce an inflammatory response to promote healing.
Correct. Yep.
Okay.
And again, it's in those areas that don't get the good blood flow, tendons, ligaments, or joints, that need that extra stimulus. Or if the body initially started healing it in that first 6 weeks, that initial acute phase, and didn't complete the job, a lot of times the body just forgets about it, moves on to the next thing, and then you're stuck in that chronic state. So whether it's the prolotherapy or the PRP, we're irritating it, trying to get that new signal so the body revisits the area and then finally heals the job. So go ahead.
what does the literature say is best clinically, PRP versus Prolo, or do they vary based on their certain
it varies
conditions?
based on the severity of the condition. And, the other thing too is if I can think I can get someone better with 3 prolotherapy injections, usually the cost is a lot lower, from the prolotherapy to the PRP. So there are a lot of times where I'll do a prolotherapy or a few prolotherapies to see if we can get them over the hump to get them there. But if I know it's a partial tear or something more severe, I'm usually going straight to the PRP instead of saying, all right, you got to come 15 times for all these little prolotherapy injections. I'd rather just get it all done with a 10 billion platelet PRP injection and be done with it as far as that goes.
Perfect. The next question, I think, is what sets you up so differently from everyone else that I've seen is the fact that sometimes in certain conditions you do PRP injections along with stem cell injections, which is fascinating because I can't find anyone else that's even closely doing anything close to that up here. So can you explain to us what is the reasoning for doing both and then why?
All right. So, the PRP, just like everything we went over, it is a great stimulus to send other cells, to attract stem cells to the area. So I always like having that component of it. There's different growth factors in PRP than in the product that we use for both bone marrow and adipose stem cell. So there's different growth factors, there's different agents that attract more cells to the area. So I used to just do PRP or just do adipose or bone marrow, and that was it. But it's been since 2018, so almost 7 years, that I thought, all right, I'm already doing the stem cell into this knee joint. I don't need to do fill the whole thing up with stem cell. We're already getting millions of stem cells in there. So if I can concentrate those platelets down to 1 milliliter, the same that I would normally do in 4 or 5 milliliters, then I can have all the platelets in there and all the stem cells. And why not? We have enough room in there to get both signals, because stem cells also act as a stimulus to get more stem cells to do that healing. So why not have both of the very effective techniques in one? And that's been having great results in the literature. Yes, it's hard to see people, they want to separate one intervention from the other, but that combination has been working great for both arthritis as well as the tendon and ligament injuries as well.
Yeah, so that's great stuff, and I think that's a big differentiator for you and your group down there at Florida Regen. It's like I haven't seen that, and it's awesome stuff. So this is another question from patients because they say this all the time, whether it's PRP or whether it's stem cells. They're like, if the person is an older patient, say like 60s, 70s, 80s, they're like, I don't want my old stem cells. I don't want my old blood. I'd rather use like young blood. So if someone is an older individual, does their own blood and their own PRP injection work still? Or is it, as you stated earlier, do you just have to get more of their blood because platelet count is down? And is that true or not regarding if, like the older they are, it doesn't work as good because of their blood is old?
Yeah, and I'll start this by saying most of them are saying that because the groups around the country or the companies that want to sell umbilical cord stem cells will say your cells are way too old. You need the baby stem cells. You need the 1 day old or 1 hour old stem cells. And they're doing a great job marketing it because a lot of my patients will say that, but there is no evidence that the umbilical cord stem cell are any better than your own 50-year-old, 60-year-old, 70-year-old stem cells. If our stem cells didn't work, we would not be alive. You get a cut, your skin wouldn't regrow like it normally does. You have an ache and pain, it wouldn't go away. So our stem cells, up to the day we die, are still working. And that's the hard thing, is that there's so many companies that have pushed these stem cells in the US, where technically since 2019, FDA specifically said we cannot do these outside of a clinical research study. That a lot of companies are still doing these against the FDA's approval. That we're having to kind of fight that battle of All right. This is what all that free steak dinner you just went to where they told you these are the best stem cells ever. And I've had at least 400 patients tell me it was a great steak dinner. And then they walked up to the front and they said, if you sign up today, we'll give you 400 or $2,000 off if you swipe the credit card right now,
Yeah.
which is very disconcerting. And a lot of those people are saying, oh, my shoulder hurt. They gave me stem cells in my shoulder. And I said, where did you get those? And they said, I don't know. They just kind of stuck them in there. They didn't take an x-ray, an MRI. They didn't really understand what was going on. So it is hard kind of dealing with the two variables where it's like, yes, you have to have these baby stem cells. This is the only way to do it, where there is no research that says those are any better. So every company that comes to me, I say, where's the research? Where's the research? They're spending all their research and development money on marketing,
Marketing,
which
yeah.
is not the right way to go about business
Yeah.
in my view.
Yeah. This is another thing how I love your clinic because your PRP injections are using the patient's own blood. Your adipose tissue stem cells and your bone marrow stem cell procedures are using the patient's own bone marrow and adipose tissue, so they're using their own stem cells. So someone asked us, and I didn't even know the question is, but is there any negative effects of a PRP injection because you're technically using your own blood? Is there any negative effects of a PRP injection?
So temporarily, we can make your shoulder, your Achilles, whatever it is, a little bit worse for a day or two. So they're not, but that's kind of the reaction we want. You have tennis elbow. We're injecting right into the bad part of the tendon to get a reaction because that's been going on for at least 6 weeks, some people 6 months, some people 6 years. So there was an initial stimulus, there's injury here. Let's send cells here. But the body didn't do the job. So we get in that chronic state. And this is what we need to get it out of it. So I tell patients, kind of like you just twisted your ankle. You got an injury there, your ankle's going to swell up, all this blood's going to go there to try to heal it. That is a similar concept of what we're trying to do in a tennis elbow, in a rotator cuff, and an Achilles, where we're trying to make a new reaction so the body finally completes the job and does the deal. So temporarily, worsening pain, worsening swelling, stuff like that for a day or two is the negative side effects. But the other thing would be if you're not using ultrasound guidance or fluoroscopy guidance, yes, you could stick a needle through the wrong part of the body, into a vein, into a nerve, something like that. But if you're using good guidance, you're using the patient's own cells, own blood, it's very hard to mess it up or do anything negative for the patient. And the other thing I tell them, anytime I'm sticking a needle in a patient, I say, there's a risk of infection. But on the other side of it, we're using PRP for chronic infections, like a diabetic ulcer, pumping them full of antibiotics. It's still not getting better, still not getting better. That's when we inject PRP or have a little biofilm of PRP to try to heal those infections. So it's nature's own antibiotic. So that's why in all the literature I've seen 2 cases, not of my own, but that has been published in the literature of an infection following a PRP or a stem cell. And the reason why there haven't been so many is because it's very antimicrobial. So those platelets, all the growth factors are gobbling up the inflammation, but not the inflammation, the infection. And that's why we don't see many, and that's the number one thing we worry about for surgery or for a cortisone injection is causing an infection. And you got to wash out the joint, whatnot. And so we eliminate, or virtually eliminate, we'll say, that risk of infection as far as any kind of PRP procedure.
So are physicians using PRP injections during surgery? Like, say you're doing a rotator cuff surgery repair, or you're doing an Achilles tendon rupture repair, or even like an ACL reconstruction. Are they using PRP in combination with the surgery to help expedite healing?
Yes. So there are many orthopedic surgeons that have now started doing that.
Is it a
So kind
standard,
of,
or is it more like a few people are doing it? Like,
yes, I would
is
say
it
it's more a
showing?
few people.
Yeah. Is it showing better clinical outcomes?
So that's what's variable, but same thing where these surgeons are not doing the 10 billion platelets or 5 billion platelets. So some of the studies show yes, you get a better outcome. Some of them are not. If we break them down to the good PRP, the high dose PRP versus the low dose, there's a huge variability. But it's still not covered by insurance. So even the surgeons that are doing these, the patients are paying it out of pocket. And that's the thing is PRP kits cost different amounts. If you get a 5 milliliter tube, and you spin it for 2 minutes, that's way cheaper than, the kits that are $200, $250, $300 that use much more blood. So I'd say overall, the consensus is yes, they are helping. You're getting quicker results or better results or less failures of a rotator cuff with the PRP added on. But if you look at individual studies, some of them work, some of them don't. And most of the time it is dose related. And so the higher doses are getting better outcomes. Mm-hmm. So I'd say it's becoming more of the norm. When I started doing this, 15 years ago, there were a handful of surgeons that were adding it to it. I was lucky to be at Andrews Sports Medicine in Birmingham, Alabama, where they were doing that at the time. But now I'd say, I do not know the numbers, but a significantly higher percentage of surgeons that are using this intraoperatively than there were 5 years ago, 10 years ago.
Okay, yeah, perfect. So what should a patient expect if they're going to get a PRP injection? Is it something they have to come in a day prior and you withdraw the blood and then you do it and they come back the next day? Or is this a within session procedure? How long does it take? Like, what should they expect if they're going or coming for a PRP injection?
All right. And so, my own philosophy, but also the FDA's philosophy is all of these have to be same day, minimally manipulated procedures. And that's in their wording on all the recommendations and the bylaws and whatnot. So typically we will schedule for an hour, maybe hour and a half for the patient to come in, get oriented, draw the blood, count the platelets, spin it down twice. And then once we have the product, the actual injection, depending if it's one spot versus two spots versus tendon versus ligament versus joint, that's all ultrasound or fluoroscopy guided. But typically, yes, it's an hour, hour and a half, same day procedure. And then the typical game plan I give them afterwards is, depending if it's upper or lower extremity, is let's see what you're doing the next couple of days, and we kind of plan it around that. So if you did a PRP on an Achilles tendon and you're a plumber, you're not working the next 2 days. I want you to take the day of the procedure off, the next 2 days off, kind of let it soak in, everything get calmed down a little bit before going back to activity. So most patients will say the day of and the next 2 days, let's take it as easy as possible. I want you to do gentle range of motion. You can do ice, you can do heat, and really that's about it. If you have a desk job and you're just sitting there, as long as you can stand up and down every half an hour, I'm okay with patients going back to that. But any kind of physical activity, I really want to limit for those first 3 days. And then this ties in perfectly with what you do and who you are. Typically by 10 to 14 days, I'd want the patient back in with the physical therapist to start strengthening that tendon or strengthening the muscles around the joint. But I like to give it at least 10 days until you're doing that strengthening. If you're doing dry needling or massage or any of those hands-on modalities, I'm fine with you getting back in the next day with a physical therapist if they're doing that. But true strengthening around a joint or on the tendon that we treated, that's what I want to wait a couple weeks on as far as that goes.
What do you like
that's kind of
with Shockwave?
So Shockwave, I usually will do, again, depending if it's joint or tendon, I like to hit it right before I do the injection.
That's awesome.
We'll do the Shockwave, kind of prep the tendon, the muscle, whatever it is. So when I'm doing the PRP, it's already really set up for the injection. And then, yes, the next week we could start hitting it again with either, the radial or the focused shockwave, laser treatment, hyperbaric, all the things that we kind of supplement to try to get the best outcomes possible. We can start those right away, but the true tendon loading, tendon strengthening would start at 2 weeks. And what I tell every patient as far as long term, we've kind of talked about this a little bit, but typically 4 to 6 weeks till you'll notice, all right, maybe I'm in the same pain, but I can do more now, or I can do the same amount of stuff, but I'm in less pain. What we hope for is less pain, better function. And that's when, 95% of the patients will tell me they'll start noticing it at the 4 to 6 week mark. And then back to tendon, once we get to that 4 to 6 week mark and we're doing well, that's when we really push up the loading. So that's when we introduce negative or eccentric exercises, or not me, but I'll say you or the other doctors of physical therapy. We'll start going from the regular strengthening to the eccentric strengthening, because those connections have been made, and then we can really start pushing it more at the 6 week mark.
Yeah, I'm sure every patient asks you this question, but does the PRP injection hurt?
So I would say, I don't want them to have unrealistic expectations. So yes, it can hurt. It's never horrible where, you got to go to the ER or something like that. But there are certain areas and certain individuals that it hurts more or less for. So, we usually do not pre-medicate as far as giving a pain medication or whatnot. If a patient's a little nervous, we do have laughing gas available. We have a couple different, anxiety pills that can kind of help with that, just to kind of lower that pain threshold. But really, it's just the thought of it before I do the injection. So we do have that available. And if somebody does get a bad reaction, say I go in for tennis elbow into the extensor tendons there, and it does flare up, usually it's 5-10 minutes where it's kind of really on fire, and then we kind of have a big drop down and it starts feeling better. But like I said, I want the patients to prepare for 2 or 3 days where it could be a little worse than it was, right before the injection.
You did touch on this a little bit when you talked about laser photobiomodulation, shockwave, and stuff like that. But is there anything after a PRP injection that can help expedite the results or improve the PRP injection, or help even increase healing even more, that we just mentioned?
Yeah, and we could talk for hours on this, because we do a lot of preconditioning before, whether with IV, nutrients, NAD, methylene blue, glutathione, ozone, all these things to try to prep the whole body. So more of a systemic response as far as that goes. Because say you have a diabetes or something, and your body's constantly having to deal with that, there's less available, we'll say, helpers available to kind of heal that tendon. So we would like the patient as healthy as possible before we do that, to get the best possible outcome afterwards. So that's one thing, is preconditioning. Every time with PRP, we have a certain device we're sticking the syringe in that's already made the PRP for photobiomodulation. So that activates more of the platelets. That creates a better environment with the PRP for the injection. So we do that with almost every patient. Right afterwards, we can hit it with a class 4 laser. That, if it's really painful, is going to calm it down right away, but it's also going to activate more of the platelets through the photobiomodulation. So those are 2 things that are huge that we do right before the PRP injection and right after the PRP injection. So one is LED lights that photo activates the PRP, and then the class 4 laser right after. And then, yes, we do use the shockwave treatment and the laser down the road to keep activating and keeping these processes working on all cylinders. So nice. 100%. There's a lot we can do before and after to further these results.
I am hearing some phenomenal outcomes with regen medicine. This is not just PRP, but also stem cells, like even like orthopedic physicians are like getting mad at regen medicine physicians because you don't need surgery anymore. Like I'm hearing like there's times where people have shoulder labral tears doing stem cell and PRP injections with PT, the labrum's healing and they're getting back to normal. Is there any specific cases or really cases you've had recently regarding PRP that just showed a phenomenal outcome? Like a really cool case that you just had recently?
Yeah, well, I would say overall, if I had to choose a tendon to inject, I would go for the glute medius, glute minimus. I mean, they're right along the same port, right on the outside of the lateral hip. And I would say just over the years, I'm having, over 98% success rate with that. There was a huge study out of Australia that showed great results at 1 year. Then they came back at 2 years, and they still maintain those. So I would say that is one of my favorite areas to inject, just from the almost perfect results that we've gotten so far. But even in those with the big gaps in them that are saying, oh, the surgeon says I have to have surgery, have to, fix this or it's not going to heal. Those are the cool ones that where we can get them back, get them doing everything they want without the big surgery, without the big time off of
Hmm.
work or of life or whatnot. So those are really my favorites. I've definitely done a lot of orthopedic surgeons, and there's been a few that says do not tell my colleagues I'm doing this, just because it was like
Yeah.
taboo at the time. And when I started right out of fellowship was in Tucson, Arizona, but it was basically 30 orthopedic surgeons, and we had a pain guy, another sports guy, and myself. And it started out like, oh, he's going to do PRP. Okay, let him do that. He can do whatever he wants. But then after a year or two of those results, then they kind of tried to tighten the reins up. And yeah, I would say some of them did not like me getting their patients better
Yeah.
without surgery. And that's just a fact. If you have a hammer, you're looking for a nail to hit.
Yep.
So they're not looking for PRP to charge their patients. They're looking for the surgery
Yeah.
because that's what they know and have been trained to do.
Yeah.
So yeah, there is definitely some bias. It's not an equal playing field as
Are you
far as.
using any peptides at all down there?
So yes, and I've been doing them, for probably over 7 years. But in 2023, the fall of 2023, basically everywhere I was getting my peptides were the big compounding pharmacies, and they are regulated 503A, 503B by the FDA, where they can test everything, make sure it's pure. But they basically said the two ones that were working the most, BPC 157 and TV 500, that none of the compounding pharmacies could produce those anymore. So I'm in a difficult position now where I know those work, but I cannot prescribe it to a patient. So the only places that are putting them out are research companies that usually say on the bottle, not for human use or for research purposes only. There's better ones, there's worse ones, but all I can do now is say, yes, these work. This is a legitimate company. This is a legitimate company, but I cannot personally prescribe it like I could, a regular pharmacy, because of those regulations by the FDA. So I think they work. There's some oral forms of BPC 157 that I think work great. But as far as the injections, as they stand right now, you have to get it from a research company or out of the country, and none of those are regulated as strictly as all the other
Yeah.
pharmaceutical drugs are made right now. So
If you
it's
take a
yeah,
if you take BBC 157 orally, what percent do you think you actually absorb into the bloodstream?
it's usually like 5 to 10%. It
Is
does
it
it does
is it
well
enough
in
to
the
make a
stomach.
change? Is it
Yeah,
enough to
so
make
no,
a
I've
change?
I've still seen significant results in patients, not with stem cell or PRP, that are just coming back from an injury, where I have one patient that does the oral, one person that does nothing. And again, this is anecdotal, it's not a huge study, but I've seen quicker results back from recovery from
Yeah.
injury, even with the oral one.
And you're about to say, I bet you it really fixes gut health too, because it is a gut peptide too. But
Yes.
I
Yeah.
could talk to you for hours on this one. So
Yeah.
if we stay
And
focused
real
on
quick, just
PRP.
because, yeah, no, but real quick, just because we're on the subject, there's a lot of patients that are trying to lose weight now, and all the Wegovy and Trulicity,
GLP-1s.
and all, yeah, all the GLP-1s, people will get a little nauseous the day they do it and a couple of days after. So on all those patients, I'll start them on the oral one day before, the day they do the injection, the day after. And that's really cut down on a lot of that
Nice.
nausea, the stomach ache experience. So
So
back on topic.
yeah, what advice would you give a patient who's considering a PRP injection if they're unsure if it's the right step for them?
So make sure you have the correct diagnosis. Not like the patient has to know that, but make sure you've had imaging done. Someone tells you, you don't just come to me and say your knee hurt and I pull up some PRP and inject it. I want to know if it's arthritis, if it's tendon, if it's ligament, if it's meniscus, if it's labrum. So getting the correct diagnosis and seeing what level it is. So having those images are typically what I need to kind of diagnose it. Obviously, a physical exam. If you go to a provider, they're not putting their hands on you, they're not looking with the ultrasound, they're not doing different exams. That is a huge, huge red flag.
Well
So make
said.
sure that, yes.
Note on that one.
Yes. So make sure you're getting the correct diagnosis, because this powerful thing we have, whether it's PRP or stem cell, doesn't just cure everything just by injecting it randomly. It's got to be the right diagnosis and the exact right location. So if you're not injected into the bad part of the tendon, if you're, an inch off, it's not going to get to where it needs to go. So basically what we're looking for is the correct diagnosis, the correct placement of the PRP, and then obviously everything we talked about, the correct number of platelets, knowing what's going on, whatnot. So those are the things that I would say you're looking for in a provider that does regenerative medicine. And then make sure they follow up, they're tracking their patients, they have been doing this, they didn't just say, oh, PRP looks like I can make some money off of, let's put that into our equation. You need somebody with the physical exam skills, the knowledge of orthopedic, of sports medicine. So there are great family docs, internal med docs that have concentrated on orthopedics. But it's not just every doc that knows, okay, this is rotator cuff versus labrum versus bicep tendon. You got to get all that out, get the correct diagnosis, so the treatment we're doing is going to work well for you.
Perfectly. Well said. We're going to finish up here with the last few questions, but interesting to hear what you have to say with this one. Where do you see regen medicine heading in the next 5 to 10 years? I mean, I think it's the future. The combination of orthobiologics plus tech, like photobiomodulation, shockwave plus PT. I think that's the future of my profession, teaming up with guys like you. But where do you see the future of regen medicine heading in the next 5 to 10 years?
All right. So I'm in total agreement with what you're saying. I really feel that energy-based treatments, obviously you cannot just get passive treatments and be fine. You have to progressively load a tendon or it's not going to get stronger. But adding shockwave, adding laser, adding, all the photobiomodulations to that, I think we're getting quicker, better results, more long-lasting results. So I think some of that's already here. The future's already here in a lot of the practices that of my colleagues around the country. Not, there's a handful of them that are already doing all this. What I truly feel, besides the energy-based stuff that you alluded to, is there's a lot of other stuff in the plasma that we aren't collecting that have really good molecules, really good signals. Exosome was a huge buzzword. I'd say peptides, I hear that a little bit more, but 2 years ago, all editing patients want to talk about were exosomes. So those are typically the ones we've seen out there right now are from a manufacturer that makes them from a stem cell. So it's somebody else's or allogenic exosomes. But I think the future is autologous exosomes. So there's a bunch of those in the plasma that we would normally throw away. Now we can add some medication to that, spin them one more time and concentrate all the exosomes, all the growth factors. There's something called A2M that's really anti-inflammatory that I've been using for years. There's something called IRAP, and they both kind of gobble up inflammation, help with these long-term chronic inflammatory conditions. So my ideal world is taking a sample of blood and saying, all right, I want IRAP, I want A2M, I want IL-17, I want, all these different pro-healing molecules, put them in a machine, and it spits out exactly what I want. So that's my hope for the future. That's what I've, been talking to people about, and we're still off from that. But basically having a customized thing, all right, you have a rotator cuff tear. I want to get all the platelets, but I also want A2M, I also want IRAP, and I want all the exosomes all in one product, and then let's inject it here. So that's going to be, a separation system that can really individualize all these different small molecules. But that's where I really feel the future, more personalized PRP, more personalized stem cell.
We're like seeing some of the patients, what used to take 12 to 18 visits to get people better, we're getting better in 6. Yeah. So it's like, not only is it like the future's coming, but it's like it's better outcomes for the patient, and you get better even faster, which is phenomenal. So I love this. I think the future is huge.
Yeah, and that's something to consider. This is cash pay. This is coming out of pocket, or at least HSA or a health savings account. But if you can get back to work a month quicker than you could, or you can get back to playing with your kids, or whatever you want to do, that's where it's a cost-benefit analysis where, okay, I'm going to pay a little more for this PRP or this shockwave or whatever it is, but it's going to save me a month. Is that worth it for you to get back quicker or to avoid a surgery? So it's that, cost-benefit analysis, and the quicker we can get people back doing what they want, obviously the better and happier they're going to be as patients.
Do you think insurance is ever going to catch on to this?
That's what I mean. When I started doing this 15 years ago, I said it millions of times. 5-10 years, they're going to start covering it. We did get TRICARE, which is ex-military insurance. They started covering not bone on bone, but grade 1, 2, or 3 arthritis for the knee, specifically the knee, and tennis elbow, because there's the most amount of research on that. But they also do a whole lot of PRP getting soldiers back in the military, so they knew it worked. So far, that's the only one. Unfortunately, in the U.S., besides that insurance, most other insurance just follow what Medicare goes on. Yeah. Once Medicare sets that, then they all kind of follow suit. So that's the hard thing, is getting a government agency to fully cover this. So yes, I do think they will, but I've been wrong for the last 15 years, so I'm not going to put a time, if it's going to be another 10 years or 5 years, but I know it's not going to be this year, because I would have heard about it by now for sure.
So we're at the 60-minute mark, so we're going to finish up here. But if someone is interested in consulting with you or consulting with you for an evaluation, where can they find you at?
So the website is FloridaRegen.com. So Florida REGEN.com. I'm sure
we're going to put a link and everything below too.
Okay. So we do that, and then obviously we have an email, just info@FloridaRegen.com. We have social media that's at Dr. Tad DeWald and at Florida Regen, where we're probably going to post stuff like this as well. So those are the best ways to get in touch with us.
We'll put the links to your website and everything below. But anyway, wonderful. It was awesome. It was awesome talking with you. Thanks again for taking time out of your day to go over this. Hopefully we can do it again soon and start talking about some stem cells. But thanks again, 100%. Tad. It was a blessing, and we will be in touch.
All right. Thank you, Ron. Really appreciate this. It's an honor to be on here with you.
You're welcome.